Hi, this is Tyler Foster, and welcome back to the Pharmacology section on toxicity and side effects. Now, this section is not the bread and butter of pharmacology, but there will likely be some questions on test day over this material. Now, the mechanism of action is rarely tested, but memorizing the list that I'm about to show you is going to be very important since they do appear on step 1 every now and then. Let's go ahead and cover some of the high-yield topics now. We're going to start off with a high-yield antidote to a common drug, acetaminophen. Now, acetaminophen can be oxidized to NAPQI, which is going to stand for N-acetyl P-benzoquinoneamine. Not important for test day, but what is important is to realize that this NAPQI is a metabolite, and that's going to be toxic to your liver here. So this NAPQI metabolite is going to be toxic to the liver. Now, this NAPQI can be further conjugated to glutathione to form an inactive byproduct. But in the cases of acetaminophen overdose, this glutathione is going to be depleted, so we see it going away. Now, N-acetylcysteine comes in and is the superhero in this case. So N-acetylcysteine comes in, and this is a metabolic precursor for glutathione, and therefore it can be administered to restore glutathione levels and then prevent this NAPQI hepatotoxicity. Now, interestingly, this N-acetylcysteine is also used as a mucolytic agent in diseases such as cystic fibrosis. So like I said earlier, the exact mechanism here is not as important, but it may be useful to help you remember why this N-acetylcysteine is used in acetaminophen overdose. So, what's the takeaway message in this case? In cases of acetaminophen overdose, N-acetylcysteine can be given to replenish the glutathione levels, which acts as a protective agent. Now let's talk about some cardiology. In review, beta-1 receptors that are going to be located on the heart can be stimulated to do two different things. So beta-1 receptors are going to increase the heart rate, and then they're also going to increase contractility. Now, with that said, what symptoms will a patient who overdosed on beta blockers have? Well, hopefully you're thinking bradycardia or a slow heart rate, and then also hypotension or a low blood pressure. So if a patient comes into the emergency room for a beta blocker overdose, how are you going to treat them? Well, to answer this, we'll need to recall what we learned from the pharmacoautonomics section. What kind of G protein is the beta-1 receptor? Well, the beta-1 receptor is going to be a G protein. So they go on to activate adenylyl cyclase, which then converts ATP to cyclic AMP. If you block the beta-1 receptor, you're going to decrease cyclic AMP in the cells. Glucagon is useful for treating beta blocker overdose because it increases cyclic AMP levels in the myocardium via a different route. This bypasses the blocked beta adrenergic system. Since the heart disease is going to be one of the #1 killers in the United States, we should probably talk about digitalis, which is going to be a heart drug that you're going to see all the time on your clinical rotations. Since we're talking about digitalis, let's do a little bit of cardiology review. What is the mechanism of action for digoxin? That's right, it's a cardiac glycoside that's going to inhibit the sodium-potassium ATPase, and this leads to an inhibition of the sodium-calcium exchanger. Now this increases intracellular calcium, which leads to positive inotropy. So positive inotropy, and that simply means increased contractility. So positive inotropy will lead to increased contractility. Same thing there. To treat digitalis poisoning, what 5 things do we need to have done? We have a 5-point therapy for this. First, the most intuitive of it is going to be stop digitalis. If you have an overdose, you need to stop it. Second, what you're going to do is you're going to normalize the potassium levels. Third, give lidocaine. Fourth, give an anti-digitalis Fab fragment. And finally, give magnesium, which is going to be an antiarrhythmic agent that can act as an indirect antagonist as well. An easy way to remember this 5-point therapy is with the little memory aid CLAM. Now, CLAM is going to stand for, the K is going to stand for the potassium, L for the lidocaine, A is going to stand for the antidigitalis Fab fragments, and then M is going to stand for the magnesium. So as a side note, we need to remember from immunology section, and you'll see that digitalis is going to be one of the few drugs that has a monoclonal antibody. So remember an antibody here, we've got the light and heavy chains. It's going to have an antibody as one of the therapeutic antidotes. So notice how we have an anti-digitalis Fab fragment. Digitalis is one of the few drugs that has a monoclonal antibody. Alright, we can move on and do a fun one. Now, in methanol and ethylene glycol poisoning, the actual compounds themselves, so methanol and ethylene glycol, are not as toxic as the metabolites that they're going to produce. So we need to jump back to biochemistry for a while, and we need to resurrect the enzyme alcohol dehydrogenase. So let's bring that into the picture here. This enzyme, alcohol dehydrogenase, turns methanol and ethylene glycol into toxic metabolites. So here we feed in our toxic substance, and we're going to spit out some toxic metabolites, which are going to be harmful to the body. However, this enzyme alcohol dehydrogenase is also going to be used in a separate reaction, and it's going to be converting alcohol, or ethanol here, into acetaldehyde. So this acetaldehyde is going to be, one of those important intermediates. It's going to cause a hangover after a long night of drinking. Needless to say, many of you may or may not experience an acetaldehyde overdose after taking the USMLE. A surprising yet effective treatment for methanol and ethylene glycol poisoning is going to be giving ethanol here to compete for this enzyme. So if you have a methanol or an ethylene glycol overdose, what are you going to do? You are going to get that patient drunk. Because what does that do? Well, it's going to cause an acetaldehyde buildup instead of these toxic metabolite buildups. So we're going to use this enzyme for kind of good purposes rather than bad purposes over here. So, although it's interesting theoretically, the doctors do not like getting patients hammered, so it's not looked too highly upon. So what do we do instead? Well, what we're going to do is we're going to introduce fomepizole. Fomepizole is a better treatment. It's a competitive inhibitor of the enzyme alcohol dehydrogenase. Boards like testing your knowledge on this concept. So I want you to remember two different things. You can either give alcohol or fomepizole. I doubt that they would give both answer options, but be aware that either one is acceptable in treating a methanol or an ethylene glycol overdose. Alright, now let's talk about another high-yield drug, warfarin. Now, warfarin is going to be a blood thinner, and here you'll see this all the time on clinical rotations, because warfarin overdose is going to be a common occurrence. So, you need to be prepared on how to answer the question of how are you going to treat a warfarin overdose? What is our antidote to a warfarin overdose? To answer this, we'll need to brush off the old hematology books. Now, we need to do a quick heme lesson. So, let's introduce some factors here. We have factor 2, factor 7, factor 9, and factor 10. Now, what can you tell me about these four factors? That's right, they're going to be the vitamin K dependent factors. It would behoove you to remember this because boards sometimes ask that question. Just in a straightforward answer, which of the following factors are vitamin K dependent? Now, is it factor 1? No, it's factor 2, 7, 9, and 10. Alright, so notice how these are going to be inactive at this moment. We need to introduce some gamma carboxylation to convert them to our active form of clotting factors. Now, once activated, these can then go on to the clotting cascade and act to stop active bleeding. Now, notice here that our gamma carboxylation machine requires a cofactor of reduced vitamin K. Now, reduced vitamin K comes into the picture here when talking about warfarin because we need to look at the cycle here. Reduced vitamin K is going to be used by gamma carboxylation to activate our factors. Once used, it turns into an oxidized form of vitamin K. Now that's all fine and dandy, but we need to regenerate this oxidized form into our reduced form again, so it can be used again and gamma carboxylate some more inactive clotting factors. Now, we need to introduce a machinery here. We need to introduce our epoxide reductase enzyme. Now, this is going to be the enzyme that's going to be used to reconvert our oxidized form of vitamin K back into our reduced usable form of vitamin K. Warfarin comes in and says, it's going to inhibit the epoxide reductase enzyme. And by blocking the epoxide reductase enzyme, we have less usable vitamin K. When we have less usable reduced form of vitamin K, we're going to not be able to activate our clotting factors, and when we can't activate our clotting factors, you will bleed. So, how do you treat a patient who is prescribed too high a dose of warfarin and is bleeding too much? Let's say their INR is 7.0. A normal INR for warfarin, we like to keep it between 2 and 3 for the most part. If they're at a 7.0 INR, it means that they are going to be bleeding or very likely to bleed. We need to reverse the warfarin overdose. So, in cases of warfarin overdose, let's clear the board here. We are going to introduce two treatments. We have vitamin K and fresh frozen plasma. So in cases of warfarin overdose, fresh frozen plasma is going to be given for immediate reversal of anticoagulation, while the vitamin K is more of a longer-term treatment. So giving fresh frozen plasma will provide the immediate clotting factors 2, 7, 9, and 10. For a more long-term treatment, vitamin K doses will help regenerate the usable form of vitamin K that these clotting factors need. How can this appear on a board question? That's the big thing that matters here. Let's say your patient is an 87-year-old female with AFib, atrial fibrillation, and she is on warfarin. Alright, she comes in with an altered mental status after a fall. You, being the good clinician, order a stat CT of the head, and it shows a large subdural hematoma, so a brain bleed. Now, you take a look at her INR labs. Her INR is 6.3. Now, what do you want to do immediately to treat her coagulopathy? Well, looking up here, we see that fresh frozen plasma is going to provide our immediate 2, 7, 9, and 10 active clotting factors, which can then go on to the clotting cascade and stop the bleeding. If we give vitamin K, which we would probably do anyway, it's more of a longer-term treatment. It's not going to give the immediate active factors. Heparin overdose can be treated with protamine sulfate, and protamine sulfate is a highly cationic peptide that's going to bind to heparin. So let's get our molecule of heparin, which represents the H, and we're going to have a bond to protamine sulfate here. So our heparin is bound to protamine sulfate. This is going to form a stable ion pair that is not going to have anticoagulant activity. Heparin on its own has anticoagulant activity. The protamine sulfate is not. So heparin goes on and activates antithrombin 3. Typically, AT3 is going to be my shorthand for antithrombin 3. Heparin normally goes on and activates it. In this case, this protamine sulfate heparin bound molecule cannot go on to activate the antithrombin 3. Alright, so antithrombin 3, remember its name, thrombin. We're going to have factor 2 here, and it's going to be in its inactive form, so factor 2-I gets converted into factor 2 active, so 2A, and looking at the name, this antithrombin 3 does what? So in the clotting cascade, clotting factor 2A, or thrombin, is needed for clotting. So it's going to inactivate thrombin. So it's going to inactivate the thrombin. Alright, so heparin causes bleeding by activating antithrombin 3. This protamine sulfate is going to be our antidote because it's going to bind and inhibit heparin, thereby reversing the risk of bleeding. So clinically, you need to follow the activated partial thrombin thromboplastin time, so the APTT, for a heparin, and INR for the Coumadin, which we already covered. So the warfarin, which is also called Coumadin, we need to follow the INR levels, and then for our heparin, we need to follow the activated partial thromboplastin time. So there are many other toxin-antidote relationships that are going to be useful to know, and my recommendation is to make flashcards of these. These can turn out to be easy points on test day, so you really don't want to neglect them. So let's do a practice question now. We have a 4-month-old infant that shows up to the emergency room with cyanosis. An arterial blood sample is chocolate colored. What is the likely diagnosis, and how would you proceed with treatment? A blue baby with brown-colored arterial blood probably has methemoglobinemia, a possible metabolic disorder in which there is a high level of oxidized hemoglobin. So we have Fe3 plus instead of the normal ferrous, so the Fe2 plus iron. So this is the ferric form when we normally should have the ferrous form. So oxidized hemoglobin has a lower affinity for oxygen than our normal iron, which is the ferrous. So since we have a lower affinity for oxygen, our treatment options are going to include giving IV methylene blue as one treatment choice, and then vitamin C as well. So in methemoglobinemia, methylene blue is going to be your go-to answer here. Now, methylene blue is going to increase the activity of methemoglobin reductase. Methemoglobin reductase enzyme. Alright, now this enzyme is going to help convert your unusable form, or the lower affinity form, back into its normal form. Now you can also give vitamin C here, which is going to directly reduce the ferric iron. So we're going to directly convert Fe3 plus into the ferrous form, the Fe2 plus, which is the usable form. An 18-month-old boy is going to be brought to the emergency room by his parents. He was found playing with green tablets at his grandparents' house. He is vomiting and alert. Abdominal x-ray is going to show radiopaque circles throughout the small bowel. You suspect an iron toxicity. What antidote should the emergency room physician administer to reverse the effects of the chemical that was ingested? So, in this question prompt, you can see that he was eating the green tablets, which represent iron tablets in this example. Iron tablets may appear like candy to a child. So, we need to apply some deferoxamine, because deferoxamine binds ferric ions, creating ferrioxamine. And this is going to be a stable, water-soluble complex that is then going to be readily excreted by the kidneys. So, therefore, the treatment of an iron overdose is deferoxamine. Alright, so here's a big list. This is going to conclude our discussion on the specific antidotes. Now, here's a big list of the commonly tested ones. I tried to pull aside the ones that I thought are the most high yield for the USMLE, but you want to make sure that you familiarize yourself with all of these for test day. Now, my recommendation would be making flashcards for the antidotes and quiz yourself every so often. Eventually, these should start to stick, and they'll become easy points for you on the actual test.